This is Dr. Mansoor Madani, DMD, Chairman, Department of Oral and Maxillofacial Surgery at Capital Health System in Trenton, New Jersey, Associate Professor of Department of Oral and Maxillofacial Surgery at Temple University Hospital in Philadelphia, Pennsylvania, and Director of the Bala Institute of Oral Surgery in Bala Cynwyd, Pennsylvania. Welcome back to the second part of my presentation on adult and pediatric medical emergency on the topic of cardiovascular section. Preparing for medical emergency in the dental and medical offices by having an emergency action plan in place and recognizing and then managing complication can be stressful and frightening, not only for the patient but also for the medical or dental team. Although this course is not mandated in many states in the United States, I believe that is one of the most important subjects that deserves frequent training. My goal in creating these presentations are to provide continuing education courses that are relevant, highly educational, useful in daily practice. It is up to date, required by law in some instances, and applicable to all dental as well as medical professionals. My objectives are to promote and encourage lifelong education for the dental and medical professionals and their team by presenting well-researched program in a unique online setting. Additionally, to encourage and assist all my viewers to achieve higher level of skills, knowledge, and competence. But most importantly, to provide continuing education program that enables participants to provide the highest level of care for their patients and their community. With that in mind, let's begin the second part of this multi-segment presentation on one of the very important subjects in medicine, medical emergencies. I hope by now you have watched the first part of this presentation, which covered the most essential and basic steps that one has to take in preparation, prevention, identification, and management of medical emergencies occurring in a practice. In the next two sections, I will continue with cardiovascular emergencies. Each session is divided in about 1 hour, as the research has demonstrated that attention span of listeners drops significantly after listening to a presentation of over an hour. Cardiovascular emergencies are one of the most common and serious emergencies presenting in a dental or medical practice. They are notorious in the sense that the signs and the symptoms of the emergency situations are seen in a vast spectrum of diseases, where some differentials are so benign that they do not require any further interventions. On the other hand, they may present with such vague symptoms that the dental practitioner and even physicians may miss the diagnosis, particularly if they do not have a high index of suspicion. In this video presentation, I will discuss several scenarios of patients that are being treated and emergency situations that happen. I will present their signs and symptoms and ask the viewers to think about it, their diagnosis and actions they should take to rectify the problems. Please listen carefully to this entire presentation, so if one day an emergency occurred, you will be ready, prepared, and knowledgeable to handle it with ease and confidence. So let's begin. First, the bad news about cardiovascular diseases, or CVD. Heart disease is the #1 leading cause of death in the United States. Over 650,000 Americans die of cardiovascular diseases each year. That is 1 in every 4 deaths, or 2,353 deaths each day. That is 1 person every 30 seconds dies from cardiovascular diseases. Coronary heart disease is the leading cause of premature permanent disability among the working adults. About 1 in 5 heart attacks are silent. The damage is done, but the person is not aware of it. And the bad news about the cerebrovascular accident, or CVA, there are about 795,000 new or recurrent stroke each year. On average, someone dies of a stroke every 3.5 minutes in the United States. There are about 401 deaths from a stroke each day. After 2020, due to COVID-19, the number of people dying from CVD or CVA is expected to significantly increase. Some researchers have found that at least 27% of the increase in death rate is due to COVID-19. COVID-19 patients with pre-existing heart diseases are more susceptible to suffer a heart attack or develop congestive heart failure. COVID-19 poses a challenge for heart transplantation, impacting donor selection, immunosuppression, and post-transplant management. Now, when we look at the economic cost of cardiovascular diseases, it is projected to be $351 billion per year, $209 billion for healthcare expenses, $142 billion for lost productivity from death or disability. In order to review the cardiovascular section of the medical emergency, we need to first look at a few basic medical terms. Acute coronary syndrome, or ACS, is a term used to describe condition associated with sudden reduction of the blood flow to the heart, ranging from unstable angina to acute myocardial infarction. Aortic dissection is a tear in the lining of aorta, and I'm going to show that later. Infarction, death of the tissue due to loss of blood flow and lack of oxygen. Ischemia is poor oxygen supply to the tissue. And then pulmonary edema is abnormal buildup or collection of the fluid in the tissue and air spaces of the lung. Sustained tachycardia or fast heart rate is persistent heart rate of 100 or greater caused by a clinical or psychological condition such as hypoxia or impending shock or anxiety. Thrombus is a local coagulation or clotting of the blood in part of the circulatory system. A clot formed in the blood vessel or in the chamber of the heart, in the lung, brain, and other parts of the body. We know that there are major arteries that supply the heart. The right and the left coronary arteries are the branches of aorta. Obstruction or blockage of any of these arteries could lead to a major and permanent damage to the musculature of the heart, also known as myocardium. One of the most common causes of the obstruction are atherosclerosis of the coronary arteries and their branches. So let's review the atherosclerosis and look at the pathophysiology of atherosclerosis. Atherosclerosis is an inflammatory disorder of the cellular lining of the arteries, with inflammation playing a fundamental role at all stages of the disease, with buildup of plaque on the surface of the arteries. Chronic injuries to the arterial endothelium is common and results from both physiologic and pathologic factors. Physiologic factors such as disturbed blood flow at the bending point or bifurcation in the arteries, and pathologic factors such as hypercholesteremia, diabetes, hypertension, cigarette smoking, infection, genetic abnormalities, and immune complexes. Atherosclerosis, affected site and complication. This is an interesting and important concept to understand. Atherosclerosis can cause diseases in many parts of the body. For example, atherosclerosis of cerebral artery and carotid artery can lead to stroke. Atherosclerosis of aorta can lead to aneurysm. Atherosclerosis of coronary arteries can cause angina or myocardial infarction. Renal arteries atherosclerosis can lead to hypertension. Atherosclerosis of iliac artery, femoral artery, and tibial artery can lead to peripheral vascular diseases. Here is something interesting. You may think that only very old people develop atherosclerosis. In fact, heart disease starts at least 20 or 30 years before symptoms appear. The good news is that at an early age, it is reversible. And if we pay close attention to our diet and exercise, it could be controlled. American Heart Association encourages aggressive screening of blood pressure, lipid profile, particularly if there is a family history of cardiovascular diseases or if one is a smoker or is overweight. Early diagnosis and prevention is the key factor in prevention of cardiovascular diseases. Cardiovascular disease risk factors that present in the early 40s are highly predictive of what kind of health care one will have at age 65, 75, or even 85. So let's look at heart health at any age, 40s, 50s, and 60s and beyond, according to the American Heart Association. As we get older, so does the risk increase. Here are a few very interesting factors. People in their 40s have about 70% chance of having moderate amount of plaque in their coronary arteries. People in their 50s have about 85% chance of having significant plaque in their coronary arteries. The risk, of course, is much higher in men. The CAT scan on the left here shows the beginning of atherosclerosis on a descending aorta's intimal vascular wall in a 45-year-old man. In the 3D colorized reconstruction of a 55-year-old man, you can see in blue color the plaque in the descending aorta as well. So, watch out, as the next victim of cardiovascular emergency could be you, no matter what age you are. Now that I even scared you, let's look at the risk factor for coronary artery diseases, or CAD. Obviously, if our cholesterol levels are high, known as hyperlipidemia, the risk is higher. Family history of heart attack, obesity, or hypertension are major risk factor. Look at one of my patients' blood pressure on the bottom left side of this slide. It was 198 over 124, which I repeated on both of his arms, and it was still high. Of course, you would want this patient to go to the emergency room or see their physician immediately before you do any procedure. Diabetic patients as well as smokers have 2 to 3 times more risk of cardiovascular diseases. Alcohol consumption, lack of physical activity, older patient 50 plus or postmenopausal period, use of oral contraceptive, and stress, and finally depression, all are the risk factor for cardiovascular diseases. Elevated C-reactive protein and high homocysteine are markers for inflammation and are also major risk factor for cardiovascular diseases. On the other hand, elevated troponin protein in blood studies is diagnostic for myocardial infarction and is a great marker for coronary artery disease. Troponin levels are usually so low that standard blood tests are unable to detect them. Even a small increase in troponin can indicate some damage to the heart. Normal range is below 400 of nanogram per ml, or 0.04 nanogram per ml. Probable heart attack is when troponin level are above 0.4 or 4/10 of nanogram per ml, or 10 times the normal level. Also in EKG studies, ST elevation, ST depression, T-wave inversion, or pathological Q-wave may be used to diagnose myocardial ischemia or an infarction. When we speak of cardiovascular emergency, we should look at 2 points as it relates to the muscles of the heart, or the myocardium, as I said before. How much the myocardium needs oxygen and how much supplies are there to oxygenate the heart. Basically, we either have a decrease in oxygen supply or an increase in oxygen demand. Decreased oxygen supply is either because of a non-cardiac factor, conditions such as anemia, hypoxia, pneumonia, asthma, COPD, low blood volume, or cardiac factors such as arrhythmia, dysrhythmia, congestive heart failure, coronary artery spasm, coronary artery thrombosis, or valve disorders. And then increased oxygen demand or consumption on the other hand, could be because of either non-cardiac factors such as anxiety, cocaine use, hyperthermia, hyperthyroidism, and physical exertion. Cardiac factor for that increased oxygen demand are aortic stenosis, arrhythmia, cardiomyopathy, hypertension, and tachycardia. Many of our older patients with cardiovascular diseases are usually on 3 medications known as ABC of cardiovascular protective drug or cardioprotective drugs. A for aspirin, B for blood pressure medication, and C for cholesterol lowering statin drugs. And when you see the patient, you see that many of our patients are on these 3 medications, that they have hypertension and high cholesterol and at risk of cardiovascular diseases. Now, with that introduction of the basic information of cardiovascular disease, let's see some practical application in our daily practice. Our first patient is a 49-year-old male who came to the office for extraction of a tooth. He has infection and complains of severe pain, had a failed root canal treatment, is upset, anxious. He was working overnight. He arrives 30 minutes late, but most importantly, he forgot to take his medication. You are behind in your schedule too, and you bring him in the room and start giving him local anesthetic. A few minutes later, he complains of severe headache, feels dizzy, his face is red, and has annoying ringing sensation in his ear. You now look more carefully at his medical information. You did not check and update his medical history before you started the procedure. He has high blood pressure and takes hydrochlorothiazide. He did not take his medication today. You also did not take his blood pressure before you began the procedure. It has been a crazy day for him, and now it's going to be a crazy day for you too. What happened, and what do you do now? How could you have avoided this problem in the first place? Of course, now you take his blood pressure. It is 198 over 124. No, that couldn't be correct. You repeat it again, and it is 197 over 135. You move the cuff to the other arm and tell him to uncross his feet and take a deep breath. His blood pressure is still 190 over 129. Before I continue, please make sure to always take blood pressure at the beginning and the end of each appointment for every patient. Now let's review the 2017, the latest American Heart Association's classification of the blood pressure. Basically, they say if the blood pressure is, the systolic is less than 120 and diastolic is less than 80, that's a normal blood pressure. But when the systolic is between 120 to 129 and diastolic is still less than 180, just 80, that's an elevated blood pressure. Then the new classification says that when the systolic is 130 to 139 or the diastolic is between 80 to 89, that is considered a stage 1 hypertension. And if the systolic is 140 or higher, or the diastolic is 90 or higher, that's a stage 2 hypertension. And hypertensive crisis is when the systolic is 180, higher than 180, and or the diastolic is higher than 120. The key treatment takeaway of 2017 hypertension guidelines are that blood pressure above 140 over 90 needs to be treated. Blood pressure above 130 over 80 needs to be treated if patient has cardiovascular event or is at risk of cardiovascular event based on age, presence of diabetes, chronic kidney disease, or calculation of the atherosclerotic risk. Goal of treatment should be to maintain blood pressure under 130 over 80. The new guideline recognizes that many patients may need 2 or more medications, and compliance may be better with combined drugs and dosage. Now remember, our patient was on a single medication of hydrochlorothiazide and his blood pressure was 198 over 124. He was sent to emergency room and was admitted for workup and change of his blood pressure medication. He was discharged from the hospital a day later. Once stable, then you can proceed to work on him again. This time, you are going to take blood pressure before and after the procedure. Generally, there are 2 types of hypertension: essential or primary hypertension, which has no readily identifiable cause for the disease, so we can also call it idiopathic hypertension. About 90% of all cases are primary hypertension. The remaining 10% of patients have an underlying cause or condition that is identifiable. This group of patients have secondary hypertension. Despite years of research on hypertension, a specific cause isn't known. The triggering point is thought to be a combination of genetic, diet, lifestyle, and age. Causes of secondary hypertension include chronic kidney disease, for example, diabetic nephropathy, coarctation of aorta, which is narrowing of aorta distal to the origin of left subclavian artery, Cushing's syndrome, which occurs when patients are exposed to a high level of hormone cortisol for a long time, drug-induced drugs such as NSAIDS, oral contraceptives, decongestants, and long-term steroid treatment, sleep apnea, and hyperthyroidism, to name just a few. Drug-induced hypertensive crisis is another issue of importance that we have to consider. Drugs and substances such as cocaine, amphetamine, PCP, appetite suppressant, fen-phen, which is now pulled off the market because it was causing significant pulmonary hypertension. Over-the-counter sympathomimetic drugs such as decongestants, monoamino oxidase inhibitor or MAO inhibitors such as tyramine, all can cause hypertensive crisis. Early signs and symptoms of hypertension includes patient may remain asymptomatic for many years. When the symptoms occur, then they might develop elevated blood pressure, narrowing and sclerosis of retinal arterioles, headaches, dizziness, tinnitus, or ringing in the ear, which are not specific for hypertension. Complication of advanced hypertension includes rupture or hemorrhage of retinal arteries, papilledema, optic disc swelling, left ventricular hypertrophy, enlargement of the left ventricle, cardiovascular accidents such as congestive heart failure, angina, and MI, renal insufficiency and renal failure, dementia, aortic dissection. This aortic dissection, I want to actually dissect it more and explain it more, because it is a potentially deadly condition where the intimal layer of aorta could rupture. Patient with significant uncontrolled hypertension could develop sudden onset of mild to severe chest pain due to aortic wall rupture or aortic dissection. Although this is not related to medical emergency, but the American Heart Association highly recommend the following specific lifestyle recommendation to control elevated blood pressure, which I think it is worth mentioning. They include weight loss, reduce sodium to less than 1500 milligram per day, increase potassium intake to 3500 milligram per day through dietary intake, and we know that banana is a good source of potassium. Increase physical activity to a minimum of 30 minutes of exercise 3 times per week. Limit alcohol intake to 2 drinks or less per day for men and 1 or less for women. Let's look at the medications that are used to treat hypertension. They include diuretics such as thiazide diuretic. Hydrochlorothiazide is an example that is very commonly used by patients. Loop diuretics such as Lasix, potassium sparing diuretic, aldosterone receptor blockers such as aldactone, which is also a potassium-sparing diuretic. Beta blockers, which are either non-selective such as Inderal, and cardioselective such as lopressor and atenolol. And then we have ACE inhibitor such as lisinopril, angiotensive receptor blockers such as valsartan or losartan, calcium channel blockers such as cardizem and amlodipine, which is again commonly used by patients. Direct vasodilator such as hyalazine, which are potent anti-hypertensive medication, or another example of is minoxidil, that is used for hair loss in addition to hypertension. These medications have many side effects. Here are some examples which are important to our practices in medical or dental practices. Diuretic, such as hydrochlorothiazide, they can cause xerostomia, postural hypotension, lichenoid reaction like lichen planus-like lesions in the mouth, and frequent urination. ACE inhibitor can cause xerostomia and cough. And of course, angioedema, that I'm going to talk about it shortly. Calcium channel blockers, they can cause gingival enlargement and postural hypotension. So my next patient is a very interesting case, but important lesson to teach all of us. Her story was that one afternoon she noticed that she had difficulty breathing as her tongue was swelling up. So she went to the emergency room stating that her tongue swelled up and she could not eat or swallow anymore. Her condition rapidly deteriorated before they could even get a past or current medical history from the patient. Anesthesia team was called in, and the patient was intubated immediately as her oxygen was desaturating significantly. The initial ER assumption was allergic reaction, so she was given 50 mg of IV Benadryl, 10 mg of IV Decadron, and 0.5 mg of epinephrine every 5 to 10 minutes. But the swelling continued to get worse. The otolaryngology team was called in who took the patient to the operating room to manage what they thought to be a massive tongue infection or maybe a bleeding. The attempt to aspirate or drain pus from her tongue was unsuccessful, so the team asked to call me as the source of this condition they thought to be dental origin. I came to the operating room, examining her tongue, which had a rubbery hard texture and was non-pulsating. Teeth were impinging on her tongue. There was no past medical history at all. We did not even know the patient's name yet. So I want to stop here and ask you, or think about it. What is your diagnosis? What would you do now? It is not infection. It is not a hemangioma, lymphangioma, or aneurysm. It is not responding to antihistamine, a steroid, or epinephrine. What do you think it is? First step is always to get her past history. So the ER team was able to identify her through a relative waiting in the emergency room, waiting room. The relative said the patient is generally healthy, but only has one medical problem, hypertension. Later, he identified her medication. It was lisinopril, or an ACE inhibitor, which is known for causing angioedema. Interestingly, she has been on that medication for over 25 years. Angioedema associated with ACE inhibitor can occur at any time and is not dose related. Now we understand why this happened. 3 days later, she was extubated, and on day 4, she was discharged. Although they continued to give her antihistamine, steroid, and epinephrine. So what do we need to know? Angiotensive converting enzyme, or ACE inhibitors drugs, are leading causes of drug-induced angioedema in the United States because they are so widely prescribed. More than 40 million patients use it for a variety of illnesses, including hypertension, MI, heart failure, diabetic nephropathy or neuropathy, and chronic kidney diseases. Unlike other types of allergies, urticaria and itchings are notably absent in angioedema. Patients most commonly present with swelling of the lip, tongue, or face, although another presentation is episodic abdominal pain due to intestinal involvement. Although this is an allergic reaction, it does not respond to Benadryl, epinephrine, or dexamethasone, as I mentioned above, because this is due to an increased level of bradykinin. Like all other allergic reactions, the medication should be stopped and fresh frozen plasma or C1 inhibitor concentrate might be considered. Dental management of hypertension is the next topic that I'd like to cover. So, as I said before, take blood pressure before and after all dental procedure. When you get an abnormal blood pressure reading, be sure to repeat blood pressure in both arms and after patient has relaxed for 15 minutes before considering referral. Avoid stimulating the gag reflex. Avoid long, stressful appointment. Early morning appointment is highly recommended. Consider pre-medication with anxiolytic drugs. Avoid dental treatment if systolic blood pressure is greater than 180 and diastolic is greater than 105. Remember, blood pressure will increase in non-hypertensive patients due to pain, stress, anxiety, and white coat syndrome, and many other factors. Document and advise patients of increased blood pressure. Anxious patients with cardiovascular disease are at risk of massive endogenous adrenaline release. Minimize the use of local anesthetic. Limit it to 2 carpioles of lidocaine with 1 to 100,000 epinephrine to a maximum of 0.036 or 36,000 of milligram of epinephrine. Particularly if patients are taking non-selective beta blocker and blood pressure is greater than 180/110. Avoid use of epinephrine impregnated gingival cord. Consider nitrous oxide or IV sedation if trained to do so, to start an IV. Avoid rapid patient position changes to prevent postural hypotension. Defer elective dental treatment until hypertension is under control. So, what would you do if there was hypertensive crisis in the dental practice? Provide high-flow oxygen. Activate EMS, called the Emergency Medical Services. Consider placing an IV only if you are trained to do so, or place an hip lock. Consider IV narcotics or benzodiazepine. Consider 0.4 milligram of sublingual nitroglycerin as it causes peripheral vasodilation to decrease blood pressure. And recheck blood pressure frequently until EMS services arrive. Treatment of hypertensive crisis in an oral surgery practice like my practice, I usually use labetalol, 100 milligram PO or 20 to 40 milligram IV is what is generally used. You can also use oral or sublingual nifedipine 10 to 20 milligram, morphine 2 to 4 milligram IV could be also used if patient has congestive heart failure. Anti-hypertensive medication and NSAID. This is an important topic to remember. The long-term use of NSAID over 2 weeks, such as ibuprofen, Advil, Motrin, reduces the effectiveness of blood pressure medications such as ACE inhibitor, including lisinopril, lotensin, and Vasotec, and beta blockers such as Lopressor. The effect of NSAIDs on blood pressure seemed to be due to reduction in excretion of sodium and increased retention of the water. This may cause blood pressure to rise even higher, putting greater stress on the heart and kidneys, causing damage to the kidneys, causing nephrotoxicity and worsening of the heart failure and even heart attack or stroke. Next patient is a 67-year-old patient with history of hypertension and diabetes. His blood pressure is 140/90, pulse rate is 110, and you tested his blood glucose and it was 126. He takes metformin, Indrall, and nifedipine to control blood pressure and diabetes. You will keep the blood pressure monitor on. He tells you that he has dry mouth. You notice lesions on the side of the cheek resembling lichen planus and possibly drug-induced lichenoid reaction. He also has gingival overgrowth. 45 minutes after the start of the procedure, he asks you if he can go to the bathroom. He stands up suddenly. You notice that he looks pale, starts sweating, feels dizzy with headache, and becomes unconscious. He is already connected to blood pressure monitor. His blood pressure was 140/90 and now is 89/52. You repeat the blood pressure and it's still very low. His systolic blood pressure dropped 51 points. Diastolic dropped 39 points. Of course, your diagnosis is postural hypotension and the treatment is the same as syncope. Most important lesson is when you're working on a patient in reclined position, don't let the patient stand up suddenly. Consider changes in the patient position gradually. Please listen and refer to the part 1 of medical emergency video for a comprehensive look at diagnosis and treatment of most common medical emergencies in any dental office, which is syncope. That's a really important subject to look at, and how to manage syncope. Remember, not every patient that becomes unconscious should be diagnosed as syncope and placed in reclined position with their knees elevated. Our next patient is an example of another condition. 74-year-old male present for endodontic procedure. Past medical history of hypertension, type 2 diabetes mellitus, hyperlipidemia, and heart murmur. Patient takes multiple medication, which includes hydrochlorothiazide, Lasix, Aldactone, Vasotec, potassium, tenormin to control his blood pressure, metformin, Victoza, and glipizide for diabetes, simvastatin to control his cholesterol, aspirin. He has no known drug allergies, no previous hospitalization, no blood pressure. No, his blood pressure is 150/80 and his pulse is 60. Before your procedure, you notice his ankles and feet are swollen. But you didn't ask him any question about that. Cone beam studies are done. Tooth number 30 needs root canal treatment. You place the patient in reclined position, administer local anesthesia, place rubber dam, and start your procedure. Once again, you didn't ask him about that observation about his ankle and knees. You proceed to perform endodontic treatment. Remember that pitting on pressure or pitting edema could be a sign of cardiovascular problem. After a few minutes, he sits up and complains of severe shortness of breath. He looks tired. He said that he feels nauseous and dizzy with a bad headache. Coughs up this bloody pink-colored, blood-tinged, foamy mucus. You check his pulse and it is rapid and irregular. He has heart palpitation. He complains of chest pain. What is your initial thought? Could it be angina? Could it be myocardial infarction, convulsion, syncope? Could it be a stroke or congestive heart failure? Of course, heart attack is one of those things that is in your mind. As the patient had chest pain, shortness of breath, lightheadedness, and feeling of being nauseous, but coughing up pink foamy mucus, swollen ankle, that when you press with your finger it does not bounce back, also known, as I said, pitting on pressure, should be an indication for another condition. If your diagnosis was congestive heart failure, you're right. The heart can't fill because the ventricular chambers are hypertrophied, thick, and stiff, or the heart can't pump because the valves are stretched and thin with far less power to pump the blood out of the ventricle. When the heart can't pump enough oxygen-rich blood to meet the body's energy need, a general feeling of tiredness and fatigue sets in. It is estimated that about 5.8 million Americans have congestive heart failure, and it's more common in elderly patients. A simple way to remember signs of congestive heart failure. Remember the acronym FACES. F for being fatigued and weak. A, activity limitation, because patients easily get tired and have shortness of breath and is intolerant to exercise. C for congestion. Fluid builds up in the lung due to acute pulmonary edema, which result in coughing, wheezing, and breathing difficulty. E for edema, or ankle swelling, which the heart does not have enough pumping power. The blood backs up in the lower extremities, then the fluid can collect in the ankles, legs, thighs, and abdomen, causing ascites, which is abdominal swelling caused by accumulation of the fluid. In the upper right quadrant of the abdomen, tenderness and painful liver. Excess fluid can also cause rapid weight gain as well. S for shortness of breath. Dyspnea, difficulty breathing. Rapid, shallow breathing. Fluid in the lung makes it more difficult for carbon dioxide in used blood to be exchanged for fresh oxygen. It makes it harder to breathe when lying down, causing a sudden shortness of breath during sleep, a condition also known as paroxysmal nocturnal dyspnea. These patients will also have orthopnea, which is discomfort when breathing while lying down, flat, like in reclined position in a dental chair. So you should remember this important fact when you perform dentistry. Other signs and symptoms include Chine-Stokes respiration, which is a hyperventilation alternating with central apnea, heart murmur, jaundice, distended neck vein as shown here on the right side of this slide, cyanosis, clubbing of the finger, also as pictured here on the right side. Drug used for treatment of patients with congestive heart failure include diuretic, ACE inhibitors, angiotensin receptor blockers, aldosterone inhibitors, beta blockers, digitalis, and vasodilators. These medications are used based on class and the stage of the heart failure and underlying medical condition. All of these medications have numerous side effects that may be apparent during dental treatment. One of the most important side effects has a great potential for developing orthostatic hypotension, nausea, vomiting, blurred vision, headache, weakness, drowsiness, and dizziness. Xerostomia and dehydration are other side effects of these drugs. Oral manifestation of heart failure as related to the medications are, as I said, dry mouth is very common, or xerostomia. Digitalis may intensify patients' gag reflex. ACE inhibitor may cause lichenoid reaction and angioedema as described before. Vasodilators may cause lupus-like oral lesion and lymphadenopathy. Now let's look at dental management of patients with congestive heart failure. Evaluate patient for history, sign and symptoms of heart failure. Take thorough medical history, review of system, and check the vital signs. Dental treatment is to be limited to patients who are in a stable condition. Defer treatment for untreated or unstable or uncontrolled congestive heart failure. The patient should be placed in a comfortable semi-supine position in a chair. More than 45-degree recline with control of body movement, which should be slow, in order to avoid orthostatic hypotension. Make sure the schedule for early morning appointment and the duration of the procedure is very short. Reduce stress, pain. Consider nitrous oxide or IV sedation. Avoid Marcaine, bupivacaine, as bupivacaine or Marcaine is a cardiotoxic agent. As far as the lidocaine, local anesthetic, try to minimize the local anesthetic. Maximum of 30 thousandths of milligram or 0.036 milligram of epinephrine. But make sure patient is quite numb. Do not use retraction cord impregnated with epinephrine. Watch for orthostatic hypotension, and I repeat this again and again for these patients. Adequate postoperative pain control is also crucial. Avoid use of erythromycin if patient is taking digitalis. Once again, remember, NSAIDs can worsen heart failure symptoms by causing the body to retain sodium and fluid, and therefore should not be prescribed in patients with heart failure. Consult physician to obtain the result of ejection fraction. Normal ejection fraction is 50 to 70. If ejection fraction is less than 30, treat the patient in a hospital setting. Watch the EKG carefully if you have EKG availability. If a patient complains of weakness or fatigue, stop the procedure, activate EMS. Place patient seated in a comfortable position with the legs lowered. Provide oxygen at a rate of 4 to 7 liters per minute. Some sublingual nitroglycerin tablets are indicated if complaints of chest pain. Usually we give 0.4 to 0.8 milligram of sublingual nitroglycerin, and that could be repeated every 5 to 10 minutes if blood pressure is maintained. Make sure to continue to monitor the vital sign. Transfer patient to the emergency room. Afterward, ask MD for additional guidance and clearance. Here is an example of a medical clearance I received from a cardiologist. Read it carefully. My patient needed a simple extraction of an anterior teeth number 8. She was discharged from the hospital last month with diagnosis of congestive heart failure, and his condition was severe enough to keep him admitted for several days in coronary care unit. The patient's regular cardiologist sent me a note, and he just wrote, "Patient may undergo dental extraction. Congestive heart failure is stable." Not a note that is acceptable for me or should be acceptable for you. We need much more information. My team obtained the complete list of medication, including PDMP and RX history from the patient's pharmacy, which showed extensive list of medication. But there was a problem with that note that the medical doctor wrote. The patient's primary cardiologist wrote. It did not come from the admitting cardiologist that was treating the patient in the hospital. It came from the regular cardiologist who has not seen the patient for the last 3 years and did not know about his recent hospital admission. He had done no new testing and on him either, but still proceeded to write that clearance. So please ask question if in doubt. In fact, in this case, the primary doctor has been managing him, his medical doctor, not the cardiologist. A short note was given to him at discharge from the hospital after 2 weeks of hospitalization, said his ejection fraction was 14 and has a serious heart problem. So let's look at the ejection fraction. Since ejection fraction or EF is a measurement expressed as a percentage of how much blood the left ventricle pumps out with each contraction. An ejection fraction of 60% means that 60% of the total amount of blood in the left ventricle is pushed out with each heartbeat. When the heart relaxes, the ventricle refills with blood. A normal functioning heart has an ejection fraction of 50 to 70%. As you can see here, a normal functioning heart has an ejection fraction between 50 to 70%. A low functioning heart has an ejection fraction of 41 to 49%. But ejection fraction of equal or below 40% reflect a poorly functioning heart and could indicate a heart failure. It is highly recommended to observe this issue and be very vigilant of EF, particularly if IV sedation is considered for treating a patient. Managing cardiac emergencies start with prevention. Ask few questions before you start. Ask the patient, do you have shortness of breath upon exertion, upon walking or exercise, or even when you lie down? Do you get chest pain on exertion, or are you fatigued or weak constantly? Can you walk up a flight of a stair without needing to rest to catch your breath or getting chest pain? Are these symptoms present at rest? Do you have any of these other symptoms, rapid or irregular heartbeat? You can also check their heart rate and see if it is fast or too slow or irregular. How about swelling or edema in your leg, ankle, or feet? In most cases, you can see the ankle swelling. Persistent cough or wheezing with white or pink blood-tinged phlegm. Increased need to urinate at night. Do you take medications for your congestive heart failure? If so, did you take it today? Many individuals might not know if they have congestive heart failure, and there are times that you may suspect that they may have congestive heart failure from their list of medication, review of system, and your initial observations. Now let's look at the next very important and common cardiovascular issues, cardiac arrhythmias. Simply said, a cardiac arrhythmia can be described as an abnormality in rate, regularity, or site of origin of cardiac impulse. Cardiac arrhythmia then is referred to any variation in the normal heartbeat, including rate, rhythm, and conduction pattern of the heart. Atrial fibrillation was discussed in part 1 of my presentation. Please listen to that very important presentation. Patients with cardiac arrhythmia could be identified by carefully assessing their medical history, knowing the type and severity of arrhythmia, also if they have any implantable pacemaker or defibrillator, and the level of control or stability should be evaluated. Cardiac arrhythmia are relatively common in general population and increase prevalence with age. Affect 15 to 17% of the population. 35% of people over 65 years of age, they may have cardiac arrhythmia. Most arrhythmias are of little clinical concern for either patient or the dental professional. However, some can produce symptoms including anxiety and loss of consciousness, and a few may be life-threatening. The risk increases in the presence of other cardiovascular and pulmonary diseases. We have to remember that patients with significant arrhythmia are at risk of fatal cardiac consequences, which can be precipitated by a strong emotional stress, various drugs, and or performance of dental procedures. In the dental practice, always check the vital sign. Patients with elevated blood pressure are at highest risk of cardiovascular disease and emergency complication. Reduce the length of the procedure as I have been repeating this during this presentation, and if possible, consider IV sedation. Although modern pacemakers are more resistant to electromagnetic interference, caution is required when using electrical devices, for example, ultrasonic or electric scalpel and electrocauteries. Although cardiac pacemaker and implantable Cardioverter Defibrillator are not new, but lately I've seen many patients with these devices, and I think it deserves more attention. So let's explore A bit more about ICD. Automated Implantable Cardioverter Defibrillator, or AICDs, or otherwise simply known as Implantable Cardioverter Defibrillator, or ICD, have been in use for more than 30 years. An ICD is a small battery-powered electrical impulse generator that is implanted in patients who are at risk of sudden cardiac death due to ventricular fibrillation or ventricular tachycardia. ICD data, including status, setting, episodes, events, will be available to practitioners through patient home monitoring system. That reduces the time between cardiac events and clinical review of the data, reduces the number of emergency room and office visits as well. Common dental procedures involve the use of electrical equipment that may come into close proximity to an implantable pacemaker or defibrillator. Most diagnostic tools using ionizing radiation such as X-ray should not affect pacemaker or defibrillator function. An antibiotic prophylaxis is not recommended. There is a possibility that exposure to some dental equipment may temporarily affect the function of an implantable pacemaker or defibrillator. Electromagnetic interferences, or EMI, may occur when the electromagnetic field from one electronic device interferes with the operation of another electronic device. These EMI signals have the potential to mimic the electrical activities of the heart or be perceived by the implantable pacemaker or defibrillator as electrical noises. So what happens with possible response of the electromagnetic interference includes inhibition of pacing treatment not provided when heart condition requires the pacing, asynchronized pacing therapy provided at a fixed rate regardless of the heart's need for the therapy, or inappropriate shock. Patient would be shocked inappropriately when not needed. So as dental practitioner, we must know about these devices and be vigilant about them. How about electrocautery devices? In practice, the most common cause of problem is the electrosurgical units. Electrocautery is best avoided in this patient with pacemaker. If electrocautery needs to be used, it should be used in bipolar mode. In case of need for electrocautery, the cardiologist may provide you with a special magnet. I'm holding one in my hand to show the location and placement of the magnet. In most devices, placing a magnetic device over a permanent pacemaker temporarily reprograms the pacer into a synchronized mode. It does not turn the pacer off, but this should be carefully guided by a cardiologist. How about implantable pacemaker and defibrillator during periodontal care? Before any treatment, consult patient's cardiologist. Device interference due to ultrasonic scaler use is unlikely, but caution should be exercised. For oral prophylaxis, consider the use of hand scaler. Also, although piezo electric scalers are documented to be safe, do not place electrical cord over the patient's chest. Unshielded pacemakers should be covered with a lead apron. So what are the symptoms of pacemaker and defibrillator malfunction? Difficulty breathing, lightheadedness, dizziness, chest pain, change in pulse rate and tachycardia, prolonged hiccup are amongst few of those symptoms. If any of these occurred, consult a cardiologist immediately. If there was a defibrillation shock, patients would hear a beep tone from the device. Moving away from the source of interference or turning off your device will usually allow the ICD to return to its normal operation and function. Final take. Being prepared to manage medical emergencies is the most effective means to prevent failure in caring for patients and avoiding deadly consequences. Now the next question is, are you prepared? The primary obligation and ultimate responsibility of us as healthcare professionals is the timely delivery of quality preventive, diagnostic, and therapeutic services within the bounds of clinical circumstances presented by patient. Because an ever-increasing number of patients with medical problems seek dental treatment, we can expect to face situations that may threaten the physical well-being of our patient. I hope that this section of the presentation was helpful to listen and to learn a few points. Share this presentation with other colleagues and your entire team. Subscribe to our YouTube channel for our future courses, and please add your positive comments to our video. If you need to contact me personally, email me at drmmadani@gmail.com. That is drmmadani@gmail.com. I look forward to see you in future presentation, and once again I truly appreciate the assistance and guidance of Dr. Farid Madani for making this presentation accurate and much more precise. Stay alert and stay safe. The primary source of information for these courses are CDC, FDA, American Medical Association, American Dental Association, American Association of Oral and Maxillofacial Surgeons, World Health Organization, variety of scientific literature and publication, and personal experiences during the last 4 decades of studies and practice of my life. Take care. Have a great day.